You know, a few years ago when we started this dinner and this evening, I didn't quite realize how big it would be. I know we were trying to cram it all into the main dinner, but this has now become one of the highlights of our year, which is we get to understand why we do what we do. And certainly you've made yourself useful. I was at Penn when you opened the Leadership Center there, and saw all the wonderful undergraduates, including Laura Lauder's son with a skateboard who came in, and so you've been doing amazing things all over. And I know you gave myself, Bob Steele, and others a lot of credit for this, but the one person who really did create the Global Leaders Network is Peter Reiling. And he's not sitting here, but stand up, Peter. There, he's in the back, leading from behind. And Peter, he's the one who created this whole Global Leaders Network in the past 12 years. When I came to the Institute and Peter came to the Institute, he said, I want to expand the Henry Crown and show what we can do around the world as we look at these films. And Peter, could you have, I know all of the directors from around the world were meeting here today. Maybe all of them could stand too. These are the directors of the different fellowships, including our new China Fellowship. There's Karen. Great. So Dr. Amy Crockett, how did you come up with this idea? I know you had a preterm baby yourself, but the idea of making it sort of a group as opposed to let's get better medication.
Well, the group model was not my idea. Actually, the founder of the model, Sharon Rising, is here tonight, and the Centering Healthcare Institute owns and runs the model. And I heard about it for the first time when I was doing my fellowship at the University of North Carolina. And honestly, I was very skeptical about it the first that I heard. Most of what I was doing in my training was, lasers to treat twins with problems and robots to do surgery. And I thought this idea of women sitting together in a group sounded a little bit crazy to me. And I sort of just set it aside for the time being. And then when I started working in Greenville, South Carolina, I saw a lot of need in the patients that weren't in the practice that wasn't being met. So I'm the medical director for our outpatient OB clinic, and we do about 2,500 deliveries there a year. The patients are nearly all on Medicaid. Our median age is 20. Only 20% of these women are married, and less than half have finished high school.
How does it really work?
Right. So when we have all of these women with high levels of poverty, we also have very low levels of education. So Greenville County also happens to be, the school district is an abstinence-only county. So the women had very low levels of health literacy, very high levels of poverty, and that just creates a lot of social challenges for women. And so what I do as a physician, only a very small amount of time that I have with them in the office, all these other things impact them more than the health care that I'm delivering. But in centering, when we bring them in a group and we let them talk about the challenges that they're facing, you give them additional tools to be able to cope with all these other challenges that they have beyond just their health care. So I think that's one of the secrets that we can talk about, their relationships and their hopes for their family and their plans for themselves, for their future, and things that are really beyond the scope of what we were doing in traditional care. So.
And how does that translate into lowering preterm birth rates?
Yeah, we don't really know that, and that's what a lot of our research has been on, but the theory is, there's a mind-body connection, and stress causes inflammation in the body. We know that from studies of people that have heart attacks and cancer and other types of medical problems, but we think that that's one of the pathways of preterm birth. And so a lot of what we're doing on the basic sciences side of our research is looking at measures of inflammation in umbilical cord blood and gene expression of inflammation in the placentas, trying to see if that's where we're making the difference, if we're impacting some of those inflammatory pathways that may be contributing to the early triggering of labor. So.
How does it change the patient-doctor relationship?
Everything about how patients move through the practice has changed with group care. We had to change our templates for our appointments because now we have 10 women coming at 9 o'clock. We didn't have a template that said 10 people walk in the door at one time. It was every 15 minutes. And what we do in the group is really equalizing. So I don't wear my white coat when I'm in the group. They call me by my first name. They don't call me doctor. And we sit in a circle where everybody is equal. And the idea is that everybody has knowledge that they're bringing and sharing to the group. And I think that empowerment and helping women learn to trust that they know how to take care of themselves and how to take care of their families is part of what's helping them have healthier outcomes.
But doesn't that disrupt the way we do healthcare coverage, which is by procedure, by patient?
So the interesting thing about this is that in obstetrics, a obstetrician is paid the same for a delivery, whether it's at 26 weeks or whether it's at 36 weeks. And in a lot of the commercial insurances, it's bundled all together. So, you actually sort of make more money if you have fewer visits with your patients. So there's no incentive from a business side of it to prevent preterm birth. I mean, obviously we want to do that because we care about our patients, but the NICU costs are all siloed in the pediatric side of it. It's totally separate. So when you have something like centering that really has a chance of making an impact on preterm birth, the OB practices are having all of the expense, and they're not getting any of the payback. And so what we did that was so unique here was that we were able to partner with the payer, with our state Medicaid agency, for them to be able to reimburse the OB practices for the additional expenses we need to do the group care, and they reap the benefits from having the fewer NICU admissions. So it was a way of shifting.
NICU being neonatal intensive care.
Yeah,
right?
I'm sorry. Yep, those are you saw the very preterm baby that was in that video. Those babies spend a lot of time in the hospital, and if we can avoid those admissions, then that's a savings to the insurer. So this was a partnership that we did with the healthcare plans to kind of redistribute some of that cost savings.
Well, let's start with Medicare. How do you go about changing the way they deliver coverage?
Okay, so this was Medicaid. So Medicaid is for poor. Yeah, Medicare is for older. Yeah, right. And so Medicaid is a federal-state partnership, and so each state has its own policies that they can set, and there's some latitude within there to do demonstration projects.
So you went to the state Medicaid,
Yep, I did.
administrator.
Yep, there was actually a grant, and a lot of centering programs nationwide are working off of grant funding right now, and we started with just a $1,500 grant from the March of Dimes, and when the grant ran out, I thought we're not going to be able to do this anymore. I need another source of funding. Another grant came up, but we had to partner with our Medicaid agency to be able to apply for the grant. And when he saw the outcome data that we had, it was compelling enough that he said, let's put something together that we can try to expand this within our state. Let's see what happens when we put this on a broader scale. And so it was a partnership that we developed together based on the outcome data that we were seeing. And it came under we have a group in South Carolina called the Birth Outcomes Initiative, which is a group that comes together including Medicaid, the Hospital Association, the teaching hospitals, the health department, to try to improve health outcomes in South Carolina. And we did it as an initiative of that, part of that. So.
And we have a new healthcare fellowship coming out with
We
Hain Hips
We
Help and
do.
others out of South Carolina. So explain how that works, how South Carolina is sort of leading the way in some of
Yeah,
this.
so I think one of the advantages that we have in South Carolina is with the Liberty Fellowship, because there are over 300 of us now, and I was able to leverage some of the relationships through the fellowship to be able to make some of these connections happen. So our current Medicaid director is a Liberty Fellow.
Oh, so that's how
I
get it.
He's sort of carried on. We started it with the previous one, but we have good data, outcome data now, and so we carried it on. But that helps, to walk in when you're talking with another leader who understands principal leadership and has been through the same training with the Aspen initiatives to really answer the call to address social challenges. It does help. And our director of our health department was a Liberty Fellow, and she helped us get access to a lot of the birth certificate and outcome data that we needed to measure the impact that we were having. And we had fellows that were positioned in some of the private health insurance plans that helped make introductions so that we could talk to people there to make changes. So we had other fellows that were working in more of the public health space with the safety net providers that were able to make introductions there. So this project has contributions from a lot of my Liberty colleagues.
It really does show the power of the network effect. And that's sort of the key word in the AGLN program, is in fact that it's a leadership network. And it gives social capital, so you know who to call. I know Raja Nakata, who's starting a youth-geared programs for the Aspen Institute, has really focused on this idea of social capital. So could you explain, because because I think that's sort of the secret sauce of AGLN, how it worked in South Carolina, exactly what the Liberty Fellowship is, and it's worked on everything from healthcare to getting rid of the Confederate flag over the Capitol, right?
Yeah, there are a number of different. That's true. That was a main priority for the Liberty Fellows was to get the flag off the State House.
And it was Democrats and Republicans, half and half,
absolutely,
in
yeah.
the Liberty Fellowship. And right after that event, they said, okay, let's get together to figure out how we're going to solve this.
That had been something that had been percolating among the Liberty Fellowship for years. I joined the Liberty Fellowship in 2011, and since I joined, they were talking about how we need to come together to move that. And I think there was an unfortunate political opportunity that we were able to take advantage of when the moment came. And there were a number of other people beyond the Liberty Fellowship, too, that felt similarly. So.
And how does the Liberty Fellowship work in South Carolina? I mean, some people here probably don't know exactly the Henry Crown template,
Right.
you know, what it is, but Hain Hip and the foundation
I think it's
started
very similar. So yeah, it was Hain Hip and Anna Kate's creation. And
Anna
they're here
Kate
tonight.
and Jen, yeah.
And we get nominations from around the state every year, and Luann, who's our executive director, interviews all the new applicants and then helps to put together every class. She talks about the mosaic, so that it's a combination of people that have different perspectives to try to create the most dynamic class that they can to get those ideas of conscious leadership that come from all of the Aspen global networks so that they can, we can build that network across the state. And I think they've done a great job picking future leaders.
Does it help to be part of a larger network, too, not just the South Carolina thing, but the whole AGLN program?
Actually, one of the most powerful moments for me working on this project was when I was in India in my globalization seminar. It was right at the very beginning of this project, and, with my background, it was just in medicine. I've never done business. I've never done expansion projects like this before. I just found a really great way of taking care of my patients that I wanted to expand. And in medicine, they pay you for the job that you do. I deliver the baby, they pay me for that. It's not, well, I tried my best, but, that's not how it works. You do the job that you come to do. And this wasn't a sure thing like that for me. I was trying something new that no one had ever done before. I wasn't sure that I could convince other doctors across the state to change the way they had patients moving through their practice. I said, well, we'll do 10 practices, but I didn't have 10 people committed. And I was worried that it wasn't going to be a success, or I was worried that once we got beyond just my practice, we wouldn't see the same outcome data in other areas of the state. So there were a lot of opportunities for failure in that. And at the globalization seminar in India, we had a lot of venture capital people.
Real quickly, just so people understand.
Sure, I'm sorry.
There are 4 seminars that are part of any AGLN training.
Yep.
One of them is the classic Aspen executive seminar.
Yep.
But the globalization seminar is where you get to meet people from around the world in that seminar.
Yeah, so the first 3 of the 4 seminars are with your Liberty classmates, and then the 4th you get mixed up with the other Aspen Leadership Network. So actually Casey Hardin was with me in India, so we were friends from way back. But it was there sitting and talking with some of the people in venture capital and investment banking who saw my project from a business perspective and said there's a great opportunity for them to come out ahead with this. If they're gambling on you, that's what we do in business. We take a risk, and there's a ton of chance for this to pay off. Give it your best shot. That's all they want from you. They're not counting on a sure thing. Just give it your best shot. And so that really gave me permission, I think, to stretch and try things in a lot of ways without that same fear of failure. So I was grateful for that experience in those.
How do you think this could change healthcare more broadly, not just delivering baby healthcare, but other aspects?
Right. So there's a lot of conversation about buying health instead of paying for healthcare, which is what we've been doing. So how do you use the healthcare resources we have to get the best outcomes possible? And so this is a great example of investing in the prevention where you can immediately see the outcome. So what they're doing when they pay for the group care visits, and one of the parts of my project was to get a differential payment on those visits, so there's sustainability to support the program, that's shifting from that volume base, it just matters the number of babies I do, to getting paid for the quality of my outcomes now. And I'm getting this enhanced payment because I'm getting these better outcomes. So it's a great example that we use. It's in other disciplines, it's harder to see that transition because I get the delivery no matter what. These all have babies in their tummies that are coming. But when you're looking at preventing a heart attack that never happens, that's a little riskier model. But this is a very great, very tangible way that you can show we're investing a little bit up front and we're saving on the back end. So,
what other lessons are there that can be drawn for a larger group out of what you've done?
I think the biggest thing that has been the most rewarding for me about this project is seeing how engaged the people are across South Carolina about making a difference for their patients. A lot of times health indicators, especially for South Carolina, get reported. We're the bottom fifth in preterm birth, we're the bottom fifth in cancer diagnosis, we're the fifth in high school graduate. There's bad news all the time, but within even the darkest night, there are bright spots and people that are really committed to making a change. And one of the privileges that I've had with this project is really working with other really activated, excited people that want what's best for their communities, for their people, and just really needed to be given the opportunity to be able to make that difference. So to me, this has been really an example of the power of leadership and what you can do when you can just help people shine and rise to the occasion. They're just amazing physicians across South Carolina that really care a lot about the women in their practice, and it's been a great with this opportunity to, one, just meet them, but two, we give their data back to them and to show them the difference that they're making for their patients is my favorite part of the project.
Your fellow laureate, previous laureate, Bill Bynum is here from Mississippi. Do you have plans to move to other states?
So, yeah. So we've been contacted by a number of other states about doing similar projects. The key is to have that sustainability in those enhanced reimbursement payments. And so our state Medicaid director is doing some work to reach out to other state Medicaid directors to encourage them to have the same structure for reimbursement so that they can afford to make the changes they need to do this model. So we're absolutely working across the country. We have contacts almost every day. I have a call with New York on Tuesday when I get back. New York City wants to do it too. So.
Well, if you can do it in New York,
right.
You can make it here, you can make it anywhere.
Yeah.
What's next?
One of the challenges within the model that it doesn't really address is what happens for women in really rural areas. It's easy for me. I have 200 new patients a month that come through my door in my practice. I can make groups out of those women fairly easily. But when you get into some of the more rural counties where there may only be 50 women in a year that are delivering, and then in the rest of the country, when you get to really geographically rural places like Alaska and North Dakota, and where you just have a lot of space between women, how do you reach them with groups? And so we've talked a little bit about maybe trying some technology-based group interactions. Can we use an app on a phone? Young people today really connect through their phones. Will it work for their medical care? Can we have a blood pressure cuff connected to an app that's going to help with their health surveillance, and can we do the group education through that?
But what you're doing is almost the opposite of the notion of virtual, where everything's done through apps and cuffs and emailed in.
Yeah. So
what's the value of place-based in person?
And so obviously we would have to do research to make sure that works, because the human connections, I think, are really important. We had an example of a patient who came back for her postpartum visit. We do a party at their postpartum, and the woman walked in with two babies. She had two baby carriers, and we thought, there was only one baby in your tummy before. Where's this other baby coming from? And it turned out it was the baby of another woman in the group who had been admitted to the hospital for emergency gallbladder surgery. And her husband worked in a job where he would be fired if he didn't show up. It wasn't just he wouldn't be paid, he would lose his job. And so he needed to go to work to support the family. And they didn't have anyone else that could help them watch the baby while she was in the hospital, and he was trying to hang on to his job. And so this woman that they'd met in the group was keeping their newborn for them. And I just thought, before we had groups, those two women could have been sitting next to each other in the waiting room and never even made eye contact. And yet here she is in her postpartum and desperately needing help. And that's the type of thing that the group can give women. And that's why we believe in it.
It's very interesting because it's a support network, whether it's the AGLN or the groups you formed with these people. And that's what really made our country great, and I hope it'll all be that way in the future.
Yeah.
Thank you, Amy.
Thank you.
That was great.